We're going to give one more minute for people to join. I think we have about 75 people who signed up today for this wonderful presentation, and colleagues are online ready to go. So just waiting for the participant numbers to go up a bit, and then we will get started. Okay, I think we can get started now. Thank you everyone for joining. Welcome to the WeMove Adolescent Health webinar, hosted by the Desmond Tutu Health Foundation and IAVI. My name is Deborah Joseph Davey, and I'm an associate professor of infectious disease medicine and epidemiology at the University of California in Los Angeles. I'm also an honorary epidemiologist with the University of Cape Town Department of Biostatistics and Epi, along with Desmond Tutu Health Foundation. So thank you for joining us today. We look forward to an interesting and interactive session with all of you. Today, we're presenting our third webinar in the WeMove series, and the focus is on implementation science in adolescent health research. We're going to hear talks today from my colleagues, Professor Audrey Pettifor and Ms. Susan Vorkoper, in between which we'll have an artistic interlude from Olerato Tsele. This will be followed by a panel discussion in which other colleagues will be joined by Ms. Nicolette Naidoo and Melanie Pleanar for the discussion. So the topics are leveraging implementation science to address adolescent HIV, and Susan will be presenting that. And then topic 2 is training in HIV implementation science, the VITS, UCT, UNC, D43 examples from the field. So we're going to have some key examples of how implementation science is implemented specifically in South Africa. But to start off, we're going to start off with a poll. We'd like to know a bit more about what you think, and we have a quick question. Please look out for the poll, in which it will appear on your screens right now, and complete it by clicking on your preferred responses on the screen. You're going to state which statements are true or false. And you can read them here. So statement 1, you can see on your poll, is implementation science is useful in overcoming the gap between evidence-based research to practicing the thing, or the intervention or program. Statement 2, through implementation science, health practitioners identify and address the barriers that hinder the uptake of proven health interventions. Statement 3, implementation science is a multidisciplinary science that can be used to enhance the adoption of best practices in educational, health, financial, and digital technology spaces. So please click on the poll. The results are displayed. I'm just going to give everyone a couple more minutes to put their answers down. Okay, thank you everyone for participating in the poll. I'm going to share the results now. The results are shared on your screen now, and all 3 statements are true. So the first statement, everyone got that one correct, 100% were true. 3 people replied false to the second statement, but it is indeed true that we're trying to identify and address barriers that hinder the uptake of proven health interventions. And number 3 is also true. We had 2 people reply false, but it is a multidisciplinary practice that can be used in different fields. So thank you everyone for your poll answers. I'm going to introduce our first speaker. Ms. Susan Vorkoper is a public health advisor at the Fogarty International Center for Global Health Studies, which serves as a hub for project-based scholarship in global health research. In this role, she co-directs the Adolescent HIV Implementation Science Alliance and leads efforts related to global nutrition research. Her presentation title today is Leveraging Implementation Science to Address Adolescent HIV. And I think she will address some of the statements that we just heard about in the poll as well in terms of defining implementation science. So we'll cue her up.
I'm excited to join you all today to discuss implementation science in adolescent health research. My name is Vorkoper, and I'm part of the Center for Global Health Studies at the NIH Fogarty International Center. Today, I'm going to provide an overview of implementation science, then discuss where we are and how we move forward for adolescent HIV and implementation science, and then talk about an implementation science research collaboration. Implementation science takes what we know and turns it into what we do. Studies suggest that it takes an average of 17 years for research evidence to reach clinical practice. Implementation science focuses on this knowledge-practice gap, also known as the know-do gap. It looks at what works, for whom, and under what circumstances. It also examines how effective interventions can be scaled up within and between countries while maintaining equity of access. It's particularly relevant for low and middle income countries, where it can help ensure that limited resources are invested in cost-effective interventions. So let's take an example. Let's say you have a new adolescent ART program. You know from the clinical trials that it works and increases enrollment by 50% and decreases viral loads in young adolescents by 40%. So you're really excited and you roll it out. However, a year into the new program, you're seeing limited benefits. So what happened? This is where implementation science can play a part. We ask questions like, how was it adopted? Were the providers trained to deliver it? Were the trained providers choosing to deliver it? And were the people who were going to receive the intervention excited to receive it? So if we assume a 50% threshold for each of those steps, including assuming like perfect access to it, adherence, dosage, maintenance, you'll see that we end up with only a 6% benefit. This is where implementation science comes in. It takes into account all of those questions. The goal of implementation science is to enable the translation of evidence into policy and program, recognizing that researchers and the users of research have different perspectives on what evidence is most useful. It ensures that research is country-driven and responsive to evolving local contexts. You might wonder how this is really different than traditional research. I mean, you might think, that all research is health research is really about improving health. So typical research focuses on the intervention leads to improved health outcomes, while implementation science is looking at the implementation outcomes. To be clear, both address the ultimate outcomes to improve healthcare. Implementation science is more focused on the process and the how question. These can be measured at a variety of levels: population, provider, and individual. Having laid all of that out, I'm now going to apply it to a specific research area, namely adolescent HIV. Although adolescents living with HIV account for only 11% of the global prevalence, they represent 44% of new infections. In sub-Saharan Africa, approximately 6 out of 7 new infections occur among adolescents aged 15 to 19 years. Adolescent HIV is made up of children born positive as well as those who have acquired it. As these populations continue to grow, there's concern that the HIV epidemic could be reignited. The issues facing adolescents are unique. Across the HIV continuum of care, adolescents are less likely to get tested and linked to care, have higher losses to follow-up, and worse adherence and viral suppression than their adult counterparts. They aren't children and they aren't adults. The issues and barriers they face are unique. A number of the factors, including access to youth-friendly health services, gender-based violence, harmful cultural and social norms, and financial constraints and independence, limit the uptake of health services within the population. Eliminating HIV as a public health threat among adolescents in sub-Saharan Africa depends heavily on successful implementation of evidence-based, contextually attuned interventions to reduce both vertical and non-vertical transmission and improve treatment outcomes, really taking into consideration the barriers just mentioned. To understand what's been done to date, we conducted a scoping review to understand the use of implementation research and the adolescent HIV studies conducted in sub-Saharan Africa. We looked at the literature published since 2010 that included a study population of people between 10 and 24 years old, was conducted exclusively in sub-Saharan African countries, and included the measurement of at least one stated implementation science outcome. We found 44 relevant articles across 13 countries. As you can see here, more than half were in Eastern and Southern Africa. This finding is in line with a recent bibliometric analysis of HIV research in sub-Saharan Africa, which found that East and Southern Africa generated approximately 5 times the amount of research compared to West and Central Africa. While older adults and older adolescents and young adults aged 15 to 24 comprise more than half of the study population, young adolescents 10 to 14 years old accounted for less than 10%. Across the HIV continuum, the majority of articles suggest the prevention of HIV, though a third went through multiple steps of the continuum. This may indicate a shift in adolescent-specific focus towards HIV prevention strategies, such as PrEP and male circumcision, while striving to better understand implementation components related to the uptake of these interventions. The high number of recent publications, 75% were published in the last 4 years of our analysis, indicates that this is still a developing field. Looking at the IS components, studies tended to focus more on acceptability and feasibility as implementation outcomes compared to ones like adoption, fidelity, and sustainability. We speculate that this may be a matter of the availability of measurements and to what extent studies present and define their measures in the literature. Acceptability and feasibility tend to be applied more at early stage implementation, as they focus on ensuring that an intervention will be palatable to the population of interest. In contrast, sustainability and scale-up are generally just once there has been uptake and potentially demonstrated effectiveness of an intervention. We found that only 4 studies used implementation science frameworks. These are important tools for guiding research to enhance generalizability. The low inclusion of frameworks in our review further reflects the nascent use of implementation science in the adolescent HIV field in sub-Saharan Africa. This calls for increasing capacity building and mentoring opportunities, something that I know Audrey is going to discuss in her talk. We also found relatively low levels of youth engagement, which is consistent with a recent review. So almost 60% of the study's review had lead authors with affiliations outside of sub-Saharan Africa. This underscores the need for building implementation research capacity in the region. Doing so will help to ensure that implementation science is applied in a way that is consistent across the field. Our review, which found inconsistent investments across the continent, among different age ranges, and in the HIV continuum of care, calls for a balanced approach to ensure equitable attention. Finally, moving forward, it's imperative to include stakeholders in the research development and dissemination. Youth involvement in the adolescent-focused implementation science projects will be essential for developing and implementing acceptable, effective, and sustainable interventions. One way we at Vorkoper have been working to address these gaps is through the Adolescent HIV Implementation Science Alliance. The goal of the Alliance is to enhance the effective use of evidence and overcome implementation challenges for adolescent HIV in sub-Saharan Africa. To do this, the Alliance is composed of teams made up of NIH-funded researchers and their in-country partners, including government representatives, research collaborators, and program implementers who were selected through a competitive process. We recently added youth members. Since 2017, we have held annual meetings that bring together these diverse teams to discuss their research and practice, provide training in IS methods, community engagement and strategies, and discuss pressing issues in the field. In between meetings, we host webinars, engage at conferences, and support 5 action groups, including sustainability, use of implementation frameworks in sub-Saharan Africa, and dissemination, just to name a few. One of our big efforts has been to build capacity among our members more broadly. Along with a multi-day training in 2018, we've included a training component at each meeting and sponsored African scholars to attend a 2-year mentored implementation science training program. We have also supported our teams to conduct their own training, which I'll talk more about in just a moment. The results, based on an analysis of the HACI team's research protocols, found that these IS trainings that we have provided strengthen current research designs and inform future implementation science grants. Along with the activities just mentioned, HACI has supported collaborative team efforts that respond to the country and regional needs more specifically. Members have been encouraged to develop individual ideas related to broad topics, often identified by our steering committee members. To date, we have seeded 19 projects that created local implementation science alliances, which I'll say more about in a minute, and addressed youth stakeholder engagement, considered research and service adaptation to COVID, and built local capacity across multiple sectors. A key component of each project is the collaboration among AHISA teams and the response to unique adolescent HIV challenges using implementation science. These efforts allow AHISA to leverage our larger platform to enable dialogue among local stakeholders and strengthen the linkages between the evidence generators and the users of evidence. In response to our members' desires to use implementation science to address regional and country-specific adolescent HIV challenges, and as a way to seed sustainable collaborations, infrastructure, and activities, AHISA supports alliances that respond to local contextual implementation issues and increase implementation science capacity across the region. To date, we have supported 6 local alliances. The alliances include members from the Ministry of Health, universities, advocacy groups, youth, and many, many others. While all use implementation science to address adolescent HIV, they really do so in pretty unique ways. Some are focused on responding to a specific Ministry of Health question. Some focus on implementation research collaborations, and some are developing long-term mentorship for local researchers. One brings together African youth to conduct an IS training and to support the subsequent network for young researchers. AHISA has already resulted in a number of deliverables and outcomes. These include seminal publications like the Implementation Science Research Priority Setting that we conducted with IAS Cypher, and a recent supplement in AIDS and Behavior with 14 articles on various aspects of implementation science and adolescent HIV, including special populations, emerging priority topics, and application of implementation science. In addition, AHISA informed the development of NICHD's prevention and treatment through a comprehensive care continuum for HIV-affected adolescents in resource-constrained settings program, both in 2018 and the renewal in 2022. Members have also acknowledged the Alliance on successful research grant applications, including R01s and a recent Procody D43, building on one of those local alliances just mentioned, as well as funding retained outside of the NIH. We are currently working on an evaluation to capture the extent of our outcomes, including on policy and practice, research collaboration and engagement, and more. I want to end on this quote from the minister, from a member of the Zambian Ministry of Health that I think really captures the influence that one of the local AHISA alliances is having on policy and program. She says, "The Zambia AHISA team enabled us to collaborate better with the Ministry of Education towards providing and reporting on health services coverage in schools and dream community outreaches. It has also helped us appreciate existing research gaps to improve our programming. We anticipate hearing more of this as our work continues. Thank you for the opportunity to present." I'm really looking forward to our discussion and welcome your questions. Thank you all very much. Welcome.
Thank you very much to Susan for the great presentation and introduction to implementation science and the work that you're doing with AHISA on the continent here. I've put the link to the scoping review that Susan and colleagues conducted in the chat box. We're now going to be going on to the next presentation. We're going to have an artist presentation. Olerato Tsele is a 22-year-old poet from Shoshanguve, living by the mantra, taking up your rightful position while you still can. Here is her poem.
Olerato Tsele. I am a 22-year-old poet from Shoshanguve. Something I strongly believe in is taking up your rightful position while you still have time. The poem I wrote about is on implementation sciences and adolescent health. I hope you enjoy. Mother tells Naledi that the sway of her hips is too wide, that every step she takes is even wider and leading her to a night rider kind of life. The night is always moving, whispering songs Naledi's hips sway to. But mother doesn't understand. Songs sang in the nights when she was young were accompanied by men who took to feeding on innocent souls when their bellies brewed with hunger. These innocent souls sit in the bed of the teeth of these men and eat into their cavities like the carnivores they resemble. Predators often leave their prey praying for amnesia, But mother remembers everything. She remembers her silent prayers that made it out the rooms when her screams couldn't. Her fear nudging at the air in the room to sit in her lungs before those men made it theirs too. She remembers the shift in her tummy the next morning that settled last night's reality. Barren by the weight of a different world, her buckling knees carried her to the nearest blacks-only clinic. Her belly-bearing Naledi was met with the clinic's clerk's cynical smile as she said, "Come with your mother to get assisted." This is how homes are broken. And this is how Naledi's mother left home, with nowhere to go. It is easier to find a drug house than a safe house, it is known. But one must make means to eat. Mother remembers everything. So she says to Naledi that the sway of her hips is too wide, that every step she takes is even wider and leading her to a night rider kind of life. But Naledi doesn't bear the weight of her mother's world. She sets with the night and is ready for the sunrise. If there were to be a shift in her tummy, it can be stilled by a morning pill. The clinic's clerk understands and is ready to assist. Every street she walks on advocates for her health. Predators roam these streets, but Naledi refuses to be prey. Knows to walk in groups. Knows the night doesn't belong to her. Knows which steps to take if her night is taken from her. Naledi is her mother's pain, healing. What a different world it is.
Olerato, that was beautiful. Thank you very much for sharing your really beautiful poem. You are really taking up your rightful position while you still can as a 22-year-old poet. That was beautiful. We're now going to introduce the second speaker. Professor Audrey Pettifor is an epidemiologist and implementation science expert whose research focuses on understanding how social determinants impact HIV and sexual and reproductive health outcomes, particularly among adolescents and young women in sub-Saharan Africa, and developing and testing structural interventions to improve HIV prevention and care outcomes. The title of her talk is Training in HIV Implementation Science, the WITS UCT UNC D43 Examples from the Field. Over to you, Audrey, who will be presenting to us live.
Great. Thank you. Good morning, good afternoon, wherever anybody is. It is morning. I'm here in Chapel Hill, North Carolina. And I am going to try and share my screen, although let's see. Right now, I'm getting a blank screen, IT. Let's see. Is IT there? When I'm going to share my screen, there is nothing. It's just a blank.
Yolisa, do you want to try to share? There we go.
Thank you. Great. And I'll just
do you want to switch to the display settings so everyone can see? There you go. Thank you, Yolisa.
Nope. It's gone. Can people see it? I can't see it, so I don't know if.
No, I can't see it either. Okay. It was there for a minute, and there we go.
There we go. Perfect. Awesome. Thank you. Technology, the joys of going live. Okay, so today I'm going to share with you all a Fogarty-funded initiative that we've been conducting with the School of Public Health, predominantly at the University of the Witwatersrand in Joburg, since 2016. And folks at UNC have been working really closely with South African collaborators for a long time. I actually started my career working with what is now WITS RHI, was RHRU in the day, back in 1996, working on adolescent HIV prevention. And so it's really exciting to see this program grow. And as Susan pointed out, the purpose of the D43s and the Fogarty program is to train and support young scientists, in our case from South Africa, in HIV implementation science. Next slide. So I think that, sorry, I think that Susan covered this well, right? But we're at a point now, particularly in the HIV epidemic, where we have some really great prevention tools. We didn't have those, I don't know, when I started my career, which is now quite a long time ago. But, as she pointed out, the real struggle now is how we get these effective prevention interventions out, get people to adopt them, take them up, and to scale these programs so we can actually see an impact in the epidemic. So as I pointed out, we've had this D43 program in HIV implementation science since 2016, and it aims to train, mentor, and support the next generation of South African scientists in HIV implementation science. Next slide. So in this last iteration, so we've had this grant almost 10 years, and we're actually in the process of coming up on a renewal. We've partnered with the School of Public Health at WITS, and Dr. Tobias Chirwa is the other PI on this grant. We also partner with WITS RHI, Innova Health Institute, Orem Health, and UCT School of Public Health. So we have investigators from all of these institutions, and we've been working to train students who include support for both doctoral students to do a PhD and also postdoctoral fellows. So people with a terminal degree, providing things like seed funding and stipends for them to conduct pilot research and to present their findings. So this D43 trainee cohort meets monthly, and we've been providing sort of more advanced implementation science training, journal clubs, and support, as I said, from their research. And this was actually a training back in a few months ago in May at the WITS School of Public Health, where we were meeting with our trainees, and they were kind of sharing their work. And I'm going to present today some examples from some of our actual trainees of how they've been using implementation science in their programs. A lot of these institutions are, some of you are from these institutions, and so are some of the PEPFAR implementers in the country. And so thinking about how implementation science, which sometimes I think is scary because there's a lot of new language and terminology, which is why Susan went first to introduce some of the terminology, but I think it sometimes scares people off. It feels unapproachable. And really the point of this is so that we can improve programs and people on the ground can improve their program. So really trying to make it tangible and something that folks can use in their everyday practice. Next slide. Okay, so the first example I want to share is from the Orem Institute, and this is work by Dr. Tonderai Mabuto. And what he did was use this framework, I guess. It's called the Implementation Research Logic Model. And I really love this work because it pulls together lots of different components of implementation science that sometimes are siloed, like Susan was talking about some of the determinants or some of the outcomes. So outcomes of implementation science, things like acceptability, feasibility, adoption of a program. Sometimes people just look at those, right? Or there's a lot of work out there just looking at determinants of, let's say, determinants of PrEP uptake, right? So we do qualitative interviews or surveys to identify barriers and facilitators, as pointed out here. We call those determinants of implementation. But we don't always put all of these things together and so that they make sense and talk to each other. And this is what the IRLM, the Implementation Research Logic Model, tries to do. And this is the article here. It's actually pretty recent from 2020, but I really like it. So it kind of takes whatever your intervention is, right? So here we could say it was PrEP, the context in which you're going to implement it, where we would identify what the barriers and facilitators, let's say, to PrEP implementation for adolescents would be. Then we need to think about an implementation strategy. So once we know what the barriers are to implementing this new intervention, the implementation strategy is going to help us figure out how do we overcome or address these barriers, or how do we support the facilitators. We then kind of go through some mechanisms of action or events that have to happen to influence the outcomes that we want to get to, right? And those outcomes could be things like uptake or adherence, let's say. Next slide. Okay, so this is if you go to the article by Smith, they have this figure there that you can fill out. And so you put all of these pieces together. the determinants, the strategies, the mechanisms, and the outcomes for your program. And like I said, I like this because it ties everything together and allows you to see if something like addressing your determinant will actually impact your outcome, because sometimes they're disconnected. Sometimes we identify these like determinants and then put in a strategy without thinking about, like, does this strategy actually impact the determinant and will it affect the outcome we're trying to seek? Next slide. So in this case, what Dr. Mabuto did was look at a longitudinal psychosocial program that Orem was, I guess, supporting for people on ART that was using motivational interviewing. So it was a service that was provided in both the clinic and the community. And motivational interviewing, if you're not familiar with it, is a specific type of counseling that's often provided that's very different from sort of didactic counseling that often folks are used to, and it uses a particular kind of model for counselors to use. So the goal of the program was to promote on-time clinic attendance for ART visits, and they wanted a high % of clients to be virally suppressed, right? The setting were primary healthcare clinics in the Northwest Province in South Africa. And the implementation strategies that they had identified were redefined duties of lay counselors, training of case managers, and a case manager handbook to basically deliver this motivational interviewing. Next slide. So once they implemented this, as many of you implementing programs might identify, right, there are concerns that were raised. So they weren't seeing improvements in their indicators. They weren't seeing more clients being virally suppressed, and that was sort of what they were hoping for, but that wasn't happening. Many clinic staff weren't participating in the intervention because they didn't believe in it. They were like, no, we don't think this is going to work, so we're not going to do it. The service was not being offered to adolescents and young adults because the staff didn't have skills to support clients in this age group. And the clinic staff weren't adhering to standards of motivational interviewing, which is, right, that's the point of the intervention. So if they're not what we call fidelity, if they're not actually like implementing the intervention, like why would you expect to see an improvement in outcomes? Next slide. So what they did is they identified the determinants of what was going on in this program, right? So what are the barriers and their level of influence on the outcome? So what they found out was that the service providers felt that motivational interviewing was too complicated. They can't implement what they were trained in, and when they try to change things, they're told they're doing it wrong, right? So they feel kind of unmotivated. They implemented a similar intervention before and it didn't work, right? So this can kind of talk about characteristics of the implementers, their knowledge and beliefs about the program. The intervention doesn't fit in the current workflow. So this is about compatibility of the intervention to the workplace setting. And then they don't have the skills to provide support for young people and young adults. And this has always been a problem at this clinic. So sort of self-efficacy, the staff did not feel like they had the ability to counsel young people. Next slide. Okay, so then after they've identified the determinants, like what are the things affecting implementation of the program, they then needed to think about strategies to address these things. So you can see in blue the current strategies they were using, and then what were they going to do to promote adoption and implementation of the program? And given what they now know, how can they address those factors, those determinants that were raised, right? So here, I won't go through all of them, but you can see some of the strategies, right? So like having champions, having refresher training, having an on-site mentor once a month, providing consistent feedback on intervention delivery and indicator performance, having local learning collaboratives to improve service delivery and supporting young adults. Next slide. Okay, so this is where we put it all together. And this is where you would sit down as a team or as an implementer and try to put all these pieces together, right? So here we have the determinants, right? So one of the things, the intervention characteristic was high complexity, right? They said this was a complicated intervention. They then tried to come up with strategies to address specifically that issue, the mechanisms through which that strategy would then impact the outcome. And if you see these little superscripts of like the A, B, C, Ds, so let's go through one. So if we start with the intervention characteristics, and we talk about high complexity and low adaptability. Okay, so a strategy B. So what were they going to do to address that? They were going to revise the handbook, right? Revise the training materials that folks could use. How did they think that that was going to impact the outcome? They thought it would improve knowledge and the intervention. And then they thought that that would improve, here you can see the B, acceptability and fidelity. So how well, so right, how acceptable it was to staff, fidelity, how well the staff actually were able to deliver the program as it was intended. And you can go through all of these, but what I really love here is that it links, right? We're thinking about the determinant, the strategy to impact that, the mechanism, and how that's going to actually implement this or affect the specific outcome. So they're not in separate silos, they're all talking to each other. Okay, next slide. Okay, so that was example one. I know I'm probably running close on time. And I loved that just because it actually like uses different components of implementation science and doesn't just focus on like one thing. Here's a more simple example. It's not simple, but it's not as complicated maybe, from Inova Institute. Kate Reese presented this work in May. So this is an example that's actually published from the Inova team looking at ward-based outreach teams that were introduced by the National Department of Health in South Africa. And it's sort of a support program for community health workers who play an integral role in provision of community HIV services, right? So they're a crucial link between the community and the clinics, the public health system. So what they were trying to do was to sort of examine facilitators and barriers to successful implementation of this program in Mopani district in South Africa. So they'd had focus group discussions with community health workers and primary healthcare nurses, and with community members who are accessing services, community leaders, and social workers. And when we talked about a framework, they used the CFR, which if we go to the next slide, we will see here. So this is a very common framework that is used a lot. It's called the Consolidated Framework for Implementation Research by Dan Schroeder. You'll see the citation. It's actually so popular, they have their own website. This was actually first created in 2009, and it was updated in 2022 based on feedback from people using it in the field. But it essentially identifies different pieces that can, again, impact intervention, uptake, implementation. So you can see kind of there's what we call the inner setting and the outer setting, the process, and then kind of core components of the intervention and adaptable pieces. So if we go to the next slide, you'll actually see they took the CFR and they then applied the information they got from their qualitative interviews to the different levels here. So here in the outer setting, things that they identified in terms of networking was that there was a lack of support from NGOs, DOH, and other groups for the program. Support, there was like informal support, therefore, from the community because there wasn't sort of like formal support. There was inadequate integration of HIV programming into the facilities. Then in terms of patient needs and resources, there was obviously denial and fear of stigma and poverty that were impacting the uptake of the program. And then they had sort of external policy and incentives that they identified. At the next level, which are intervention characteristics, go back, sorry, real quick. Thanks. Complexity, so you can see the number of services required per patient, households to be visited. So these things were complex and challenging for the teams to actually implement. Next slide. At the inner setting, there were compatibility issues. It was unacceptable. The community health workers weren't acceptable in the community. Poor integration into the healthcare system. I won't go through all of these for time, but you can see that they basically, what the CFR is helpful because if you're familiar with the socio-ecological model, like it thinks about more than just the patient, right? Or more than just the healthcare provider, or more than just the clinic, right? It's thinking about all these different levels that can impact a program, which sometimes we aren't really good at doing. And it might not be something at the clinic level, right? It might be a policy or community level factor that's affecting uptake or acceptability of a program. And this just makes sure that you cover your bases and you look at all these different levels and think about them in terms of determinants of program success and implementation. All right, next slide. Okay, so just in conclusion, right, I would say that there's actually now a number of D43s in South Africa and many more in the African region now that are focused on HIV implementation science. And so there's a growing group of South African and African scientists who are experts in this. Vet School of Public Health has a short course in implementation science that they offer every year. And I will say our trainees did a one-day training for our partners that was amazing and excellent, and they are going to become, you know, stars in the implementation science HIV framework. I think something that AHISA is focused on and that a lot of us are talking about is the need for a lot of these frameworks and science were developed in Western countries. A lot of implementation science was developed in the VA system here in the US. And we need to adapt these models and frameworks by African scientists in the Africa region for the local context. And so that's a call to action for all of the African scientists to be working in this space and thinking about, you know, do these things work well and how should they be adapted to speak to the African context. And I'll just say that, you know, these are two examples. There's many more of how you can use these methodologies in your everyday practice and improve outcomes and hopefully in the long run improve HIV outcomes. I'll stop there. Thanks. And I just want to acknowledge everybody who's been involved in the program, my PIs, Dr. Chirwa and Ramaswamy, our partners, and to the NIH Fogarty International Center for funding the D43. Thanks.
Thank you so much, Audrey. That was an awesome presentation, and I loved your call to action at the end about increased adaptation of some very US-centric, I think, frameworks, you know, to the African context. Before I pass it on to the panel discussion, I'm going to ask you both a couple of questions. Susan, I hope you're on. And first, there's a comment I think that we should really read in the webinar chat from Yogan, was for saying there was also a need to focus on understanding access to and use of contraceptives, STI awareness, testing, treatment within a PHC approach. So I think that was for all of us really to think about how not just to focus on HIV in this context, but focus on the other access to other services. So I think I'll start with Susan. Susan, you gave a great presentation and I like the AHISA example. I'm wondering, now that I hear from Audrey, what is AHISA doing really to promote the adaptation of implementation theories and frameworks in the context of Africa, if anything?
Yeah, it's a good question. Are you able to hear me?
Yes.
Okay, great. Thank you so much. Sorry, I'm having problems logging into Zoom. Yeah, so, you know, this is, I think one of the sort of benefits of AHISA is that it is bringing together the sort of different the research groups that are sort of thinking about this. And so we actually have a subgroup that is focused on sort of understanding both the adaptation of implementation science theories, models, and frameworks, and trying to identify and think through what it means to develop those more specifically for the sort of African context, and thinking of it more as sort of homegrown. So this is one of the things that we've been trying to sort of do, is to kind of figure out both what's been done potentially outside of the HIV context, or certainly outside of adolescent HIV context, but then also thinking about, you know, what's needed and how we sort of get there. I think to the other comment that you just read, you know, the other thing that we're thinking about is we just started a new group that's focused on what we're calling a whole person approach. So it's again this idea of like, right, adolescents aren't just their HIV. You know, we tend to sort of focus on that because it's where we've been, and it's where, you know, frankly, some of the sort of funding is, and it's where it's been such a needed area, you know. But I think that the more people sort of think about it as the youth-friendly services, we're needing to think more about, okay, so what does youth-friendly mean in this kind of bigger context? And then I think within that, what is the role that the sort of implementation science can play, so that, you know, we are sort of having positive programs that are based on research, and that are thinking about all of these components that I think Audrey did a nice job of outlining.
That's great. Thank you, Susan, for that. And I think for Audrey, you talked a lot about implementation determinants, so really barriers and facilitators to implementing evidence-based interventions in this population. What do you think are the implementation determinants of not doing good implementation science? I think that a lot of times people are scared of doing implementation science, or it's not done, well. And so what do you think are the determinants then of a really good, implementation science intervention?
Yeah, and I think the scoping review that Susan presented actually highlights where I think hopefully we're moving beyond it, but I think there's been a bolus of research looking at like acceptability, feasibility, determinants, and that is not moving us into the actual coming up with the strategies to address those. And until we have the implementation strategies to address the barriers and facilitators, we're not going to change the outcomes, right? So that is I think where the space is moving and needs to move. And yes, these articles and these frameworks can be off-putting. In our training in May, we had a number of local folks from the provincial health department, and they said that they're this is what we do, right? This is what we're tasked with doing. When you break down the language and talk about what it means, that is what folks in the health department are doing. That is what implementing partners are doing, but it's scary. This language is kind of academic and can be off-putting. And I think it's our duty, if we want to see programs improve and HIV outcomes improve, to translate it in a way that makes sense. And maybe that is part of how do we adapt these models to be used in in settings that aren't just academia. Let's put it that way. So I would say I think good implementation science that's why I loved Dr. Mabuto's logic model, because it tied the whole thing together, right? And I think so much is focused just on the upstream, the determinants, or we just asked people afterwards, what was acceptable and feasible. I think that's very common. You implement a program. It's mainly a efficacy study. We're trying to see, did we improve adherence? Did we improve let's say adherence to PrEP? And then we just ask people what was acceptable and feasible about the program, but we don't have enough detail about we didn't collect enough information along the way to know what went wrong or where the problems were. So those frameworks will help you. And I think we really need to be moving into the implementation strategy, not the intervention. And this is where the language gets confusing. I see people, I was confused about this for a long time. We're talking about strategies to improve the actual implementation of PrEP or ART or the WOBOT program, right? That is not, so how do we do that? We need more of that, I think.
Yeah, that's great, Audrey. I see a lot of hands up and hearts and that's giving you feedback. I definitely agree that most of the scoping review as well that Susan presented earlier was really identifying the determinants, so looking at barriers to implementation, but moving beyond just identifying the facilitators and the barriers to strategies is really key. And so I hope we can do that in the future. There's a comment here, examining this again through the lens of US and Africa context. Is there a bigger focus on scaling or reaching VS depth or intensity of program implementation that you've noticed in either setting, and how that may be impacting implementation research differently between those settings? Ramon, what do you mean by VS? Not sure what VS means.
I think versus maybe, is she saying scaling and reach versus depth? So that I think.
Yes. What do you think, Audrey?
So most of my work is focused in the Africa region so I haven't done a lot of US work, but I think this is a challenge everywhere. I mean, the US healthcare system is a mess, and we don't have primary healthcare unless you have private insurance, really. I mean, that's being a little provocative, but in some ways the South African healthcare system at least provides primary healthcare to people. We can talk about all the problems, but yeah, I think this is an issue. A lot of the literature and implementation science now, even in the region, is talking about scalability, right? And I think adolescent friendly programs, I saw Yogan was on. I mean, I started my career as evaluating the National Adolescent Friendly Initiative in South Africa. And I think this has been a huge issue. We have these programs that work when they have a lot of support, right? And they have and Melanie's here, so I would love to hear her talk about this because this has been her life's work in some ways, but then we talk about scalability, and I think that's just really hard. It's really hard to take complex programs and scale them. And so I don't know if when we haven't even gotten the program right, even at a small scale, it's kind of hard to take it national. And then when you start with national programs, that's a whole nother can of worms that then are opened up that you have to deal with. And I'm sure Melanie could talk a lot about that with adolescent friendly services. But I'm just trying to look at the comments.
Let me introduce.
Susan, do you have something to say about that? I think it's a challenge no matter where you are, the depth versus breadth kind of thing. I think that's always hard.
Yeah, I think that's right. I also think that there's so many pieces that have to be put in place for the scale up and the scale out to be there. And I think that it ends up kind of pulling back to the sort of, and I think this is what we found in our scoping review and what we found in other places too, which is sort of pulling back to this, we need to know the very basics, right? We need to know how it was adopted and adapted to this context, and what was the feasibility and what was the acceptability. And I think that there's so many pieces that have to be in place, because otherwise I think what we've seen is that things try to scale up too quick, or what have you, they don't end up working out, and then people get nervous. And so I think that it's I think one of the things we need to work on is kind of figuring out what are the sort of basic, what are those building blocks, and how do we sort of get there. But I am very interested to hear what Melanie has to say.
Okay, so let me introduce Melanie and Nicolette. If you want to put your cameras on. Our two panelists today is Miss Nicolette Naidoo, who's the program head of implementation science at WITS RHI. She has 15 years public health experience and is a chief of party of a large USAID-funded community-based prep program. We're also joined by Ms. Melanie Pleanar, who is a senior technical specialist working in implementation science department at WITS RHI. She provides technical support on several projects focusing on sexual reproductive health and PrEP service delivery, and also has supported guidelines and policies in the National Department of Health. So I'd like both of you to give your feedback on the speakers and maybe even answer some of the questions that we started discussing. Melanie, you want to go first?
Hi, everyone. I was hoping you wouldn't ask me first. It's been a very, very stimulating, both presentations, very, very stimulating, very relevant and very timeless. I think that I was disappointed in a way because they raised the very points that I was going to raise. So I'm going to have to go back to the drawing board. But some of the things that really stood out for me was the issue around youth involvement and youth participation, and really teasing that out further without just paying lip service, and without it, it becomes a tick box. And I think we need to interrogate that more and subject that to more of a implementation science lens. In addition to that, I appreciated Yogan's point around HIV and the integration of sexual and reproductive health. And I think that because we're in the space of HIV and because HIV has benefited from a lot of resources and a lot of ongoing research, the rigor of implementation science in HIV programs really does need to expand to include sexual and reproductive health, which is part and parcel and the other side of the coin of HIV, be it HIV prevention, HIV treatment, particularly in the area of adolescence and HIV. We cannot exclude the components of sexual and reproductive health. And I often find that that's a bit of a missing link. So we're in serious danger of becoming too vertical and specialized and too siloed with HIV without embracing sexual and reproductive health. There are a lot of lessons that sexual and reproductive health can glean from the work that we've done in HIV. And I really look forward to building that bridge. And then finally, not finally, because there is a lot more to say, but I'm particularly interested in how we implement the findings of implementation science. And Audrey did touch on it, but I think that we really need to build the bridge between implementation science staying within the research realm and academic realm and building the bridge into implementation, particularly within existing contextual health systems. And I think that that it perhaps is a challenge and needs to be built into our implementation science design. Audrey touched on it, and I think it's about not only scalability, sustainability, and then the area that I'm particularly interested in is in how we use implementation science to inform policy and guidelines, and how that can become a dynamic, iterative process. So very often we find policies or guidelines remain static in time, and we don't then reap the benefits of subsequent implementation science, and it needs to be much more of a dynamic process. There is an enormous amount that we can learn. Currently, we're developing guidelines around HIV prevention, around PrEP, around the ring, cabalet, and simultaneously developing guidelines, and the two need to interact a lot more. So I'm particularly interested in using implementation science to inform policy and guidelines and having a more dynamic interaction between them. That's food for thought. Thank you.
Thank you so much, Melanie. Nicolette, do you want to give your perspective on the discussion so far?
Sure, thanks, Devorah. Good morning, good afternoon, everybody. I mean, I'll just probably just start off from the 2 points Mel made. I think one about I mean, I'd also written down a few points. So Mel, you've also scooped some from me. But in terms of the youth involvement, I think one of the things, and we hear very often, is this co-design phase of interventions and the need to do the co-design, because essentially you are garnering the insight, the experiences, things that work and will not work for end users, in our case, AGYW, about kind of if an intervention essentially will be acceptable and how it could be scaled. And I think that really is the critical element, because it then allows, or it becomes an indicator to you of the success of that intervention actually being taken up when it does become available. So I think just echoing kind of Mel's point there around youth involvement and it just not being an issue regarding tokenism, but them being truly part and parcel of the development, the implementation, the interpretation of data, the sharing of the results, and even in engaging with policymakers and program implementers as these interventions become available. The other piece also, again, linking back to Mel is, I think Mel's talked about the elements that will ensure for sustainability of the interventions. And that is the pieces where the research, implementation research findings are informing and translating for policy. And I think Mel's articulated that really well in that, the data ideally as well. I think one of the attendees has mentioned, how does the data feed back into this process? And, we can just speak from example where with the National Department of Health in kind of upcoming implementation science studies on the new PrEP product, the NDOH has been very keen to have data be shared very early, even if it's really early data on what uptake is, because that data starts to feed into models regarding forecasting for supply chain. And in terms of their plans for scale up of the intervention. So, it's not just only policy, but it's other aspects in the value chain where implementation science data becomes so critical. I think the other piece I also just wanted to talk about is that I think when we started doing this work as well within VITRHI, we're seeing more and more leveraging of the PEPFAR platforms or the donor platforms. And I think, Audrey, you may have mentioned this, or Susan, is that at least we're seeing a greater appetite to be able to leverage those intervention platforms that in some cases have already reached scale, and either looking to see how to optimize those delivery models or those interventions, or to be able to assess how new technologies or interventions can be folded within those existing platforms. I think that has been quite refreshing to see with the increased appetite and funding for implementation science, which I think, may not have been there and I see Audrey's nodding, with the experience that she has, it's fantastic to see kind of an evolution of that. I'm just kind of looking through my notes. And then the other piece that, and again, I'm just kind of looking through the chat, is, kind of how essentially as well are you able to capture a lot of the context of where we implement our studies, and part of that as well is understanding the communities in which we implement. And one of the resources we found has been a resource that was developed for the clinical trial setting, but can now be translated for stakeholder management or good participatory practice. And that is something that, although, yes, it could have been done for trials, can be really used as a yardstick for us as implementers and researchers to assess who to engage, at what level, having, again, being involved from the very start of the development of a research study, to assess kind of who would be influential, who needs to kind of hear the information and in what format. And I think this is the research utilization and knowledge management piece where, how do we share this information with the right audiences in the right format that truly then have an impact on whether it's policy, on whether it's a change in a program, whether it's empowering a community, or even an end user at the center of that ecosystem. So I feel for me, those were some of the maybe add-ons to the discussion as well. And yeah, I'll pause there.
Great. This is such an interesting discussion. I really appreciate both of your feedback, and I hope you'll continue. We'll take some of the questions from the chat now. So the first one is from Hanley Myberg. There's an issue of the time it takes, and anyone that's done implementation science work, it takes a long time. And which is why there's probably such a focus on putting money into whether an intervention is effective in an RCT, for example, rather than trialing things to ensure its effectiveness. Good implementation science research should ideally involve formative research to identify barriers, facilitators, and intervention contexts and development of strategies to facilitate implementation with measurement of what works best. Any inputs on how this can all be streamlined. Context is so important, but takes a lot of time and effort to study properly. Who wants to
Put it
attack
in the
that one?
chat quickly? I totally agree. I mean, yes, I hear you. I do feel like maybe there's a little movement, and Nicolette was saying this too, that even in the program space, but also in the funding space, that funders are more open to implementation science now. And I also just think like we've learned, like we've had, like prep has been, I know it's still, you know, being rolled out, but I think we have enough experiences with ART and other interventions that when we don't do this work, we don't get the outcomes we desired. And to get to this last 5%, the 95, 95, 95, this is going to be the hardest group to reach. Actually, Sinead Delaney-Morletwe, who's at Vitsar and HI and I, we've been talking about this because we're working on our renewal for our D43. And I think this is going to be the real challenge, is implementation science is going to be the answer to getting to those last 5%. We can't do things the way we've always done them and expect to see that, you know, those achievements. It's just it's too hard. So I'm hoping that funders are becoming cognizant of that and will allow you to do that work. And just in the academic space, I just have to throw out your hybrid designs. If you don't know about them, I can try and put the link in, but those are designs that allow you to both focus on the effectiveness of the intervention and incorporate implementation outcomes as well. So I feel like those are also increasingly becoming common when you're still wanting to look at efficacy of an intervention, but you are wanting to pay attention to implementation outcomes as well.
Yeah, I also want to echo what I heard Melanie and Nicolette both talk about, which was this idea of like how we engage the community. I think that one of the things that we can do is also ensure that youth and others, you know, sort of the other stakeholders are engaged in the development of the research question, like starting, you know, from the basics, like what are the research questions, so that, you know, we're ensuring that we're actually answering a question that someone sort of on the ground actually has. And then, but then continuing it sort of along the way, right? Ensuring that capacity, you know, that people are, you know, involved in the sort of capacity building efforts, are involved in the design of the research, so that by the time we're at this point where, you know, we have evidence results, it has a place to go. It has people who are engaged. You know, so often we wait till the results come out and then, you know, kind of do this like sort of mini blitz to kind of get it places. And it's probably that's, you know, something we should be doing, but it's also a bit too late. And I think that one of the things that we can really do is ensure that those voices are there throughout. I'm also going to link to an article that was in the supplement that AHISA supported around youth engagement and the ways that youth were really, you know, strongly engaged in the research. So I'll link to that too. But I think it needs to be both youth, as Melanie and Nicolette mentioned, but I think broader than that as well. And I think that that's one of the other areas, I think, along with the things that others have said, including hybrid designs.
That's great. Thank you. Another question here comes from Jane Ferguson, and I think this really touches on making implementation science more approachable and used by everyone, not just academics. So we know there's a lot of quality assurance and quality control going on. How can approaches with implementation science align with QA efforts?
I mean, so I am not the most articulate. I am not an implementation science expert, but my colleague, Dr. Ramaswamy, who's part of this is, and he can speak to this really well. But I mean, they are kind of part of like the same umbrella, like they fall under the same umbrella, right? And at WITS in the School of Public Health, our second implementation science course is actually quality improvement, QI. So, and these plan, do, cycle things. I mean, those are part of implementation science. That's a tool. It's a tool. So I think the language and terminology has kind of, to begin with, sort of isolated. People would be like, this is operations research. What's different? Why is this a different thing? And I think we just need to say these are all tools we can use to help improve program implementation and outcomes. And so I do think of quality assurance as part of that, right? Because if you don't have it, you're not going to have fidelity to the program, and you're not going to have, you know, you're not going to see the outcomes that you expect. So I think don't know, Nicolette and Susan may have more articulate things to say, but I see them as part of the same like big box kind of.
Yeah, thanks, Audrey. I mean, absolutely, I totally agree. And I was shaking my head as you were speaking, because I think this is kind of how we see it as well. I know Mel's been working in QI for years, so she may chime in as well. But it also kind of links back to the quality improvement piece, is a way to also strengthen the foundation of the system and not just the intervention on its own, because ideally we don't implement our interventions in silos. If we're doing true implementation science, we're doing it within existing facilities or existing communities. And so the QI helps us to either identify those determinants that, could either facilitate or impede our intervention, but also in a way then support the system strengthening itself. So I think that's the piece that links back to the sustainability as well, is that through this rapid learning cycles, we're doing multiple things, both for the research, but also for the public health system benefit as well. Mel, sorry, did you want to add?
No, I mean, I think we could spend a lot of time on looking at where the differences and the similarities, but I absolutely, in the end, agree with Audrey that they are a means to the same end. Very often, quality assurance and quality improvement identify a gap and work with a quality improvement team, typically, to look at ways in which you analyze and do the plan, do, study, act, which is a form of implementation science. I think the scale is slightly different of implementation science, but it is a tool within implementation science amongst many. Perhaps quality improvement doesn't always address some of the contextual issues, the external factors. And once again, and one could learn a lot from that as well to influence quality improvement.
Yeah, I think this really goes back to the question that Deborah asked in the very, very beginning with the survey, right? Which is that it's so much about implementation science is sort of transdisciplinary. And part of it is being able to have that communication between those different groups so that we're all sort of speaking the same language. I think there's a fair amount of that sort of internal translation that I think also is a key component of sort of aligning those.
Definitely agree. There was a question here. Prince Banda asked, could you elaborate on some key implementation strategies that have shown promise in bridging the gap between SRH services and female adolescents with disabilities, considering the unique intersection of those two important aspects? And just want to make sure, Prince, that you saw in the chat that Audrey has provided you a couple of great articles that help with different types of strategies that you could use to address barriers to implementation. I don't see any other questions here, so I wanted to give Nicolette and Mel a chance to ask questions as well. Do you have any questions for Audrey and Susan?
Thanks, Deborah. Maybe I'll go ahead, and I think I can pose it to Audrey. Audrey, I mean, with the breadth of work that you've done, one of the things that recently we have come up against, which I know is not a new issue, is the involvement or the enrollment of adolescents in implementation research, and recognizing, and particularly within the space of PrEP, trying to look at the ethics around this and how can we ensure the participation of young people in studies where with ethics committees, you either have to apply for waivers, or you have, or they are still insistent on having parental consent, where this could be seen as a barrier to participation in research, but also to accessing service. I mean, what is your take on that? Sorry, it's a very loaded.
Yeah, that's like loaded, right? And DTHF have done amazing work in the space of adolescence and ethics. And I mean, I feel like the South African scholars are kind of, yeah, you all have your finger on the pulse there. I do get frustrated with particular ethics committees in South Africa. I won't name any, who I think are, have insisted on parental consent for as long as I've worked there. I've seen other ethics committees in the country move and adapt and talk to the researchers and have conversations about what does this mean, to have a waiver of consent, and how can we still protect young people and have them involved in research without requiring consent, consent from a parent, which can in many cases place the adolescent at greater risk in many ways, right? By having to disclose or have a parent involved. So we could talk about a lot of things. I feel that research is, for some, particularly when we're looking at like Cabolet or some of these newer products, which I think we've shown are highly effective and safe, that is one of the few ways, research is one of the few ways for young people to access these products in many settings in Africa. And right, that's been a big advocacy issue about where is the CAB? Why can't people access it? These trials were done in these settings, and people and the population doesn't have access to the drug, and that's not acceptable, right? And I know that there's like bigger cost issues, but these things need to be thought about before trials are done in these settings. And I think bringing it back to Melanie's point and your point, Nicolette, I just think we need to keep involving young people in the work. And I will say there's been, I think, a lot of huge advances in the youth, and what used to be called advisory boards. And now I know in the Adolescent Trials Network here in the US, they're called, I think, expert consultants. I think they changed their name because they were like, what we do is really important and we want a better name for our resumes than advisory board. And we bring a lot of expertise to the table, requiring compensation. I think there's been a lot of innovation in that space about how to involve youth. And I totally agree that I think we need to keep listening to young people and interrogating how we do it. So it's not a checkbox, like you said, Melanie. And, I think that is a space where IS could help us interrogate what we're doing, and is it actually effective? Because sometimes we just have young people at the table, but is it actually improving the outcomes of what we're doing? And if it's not, why not? And how do we make it better? How do we make that better? So I sort of circled around it, Nicolette, but I think we need to be pushing ethics committees more and more, and advisory groups, to allow young people thinking, obviously weighing safety, right, for sure. But yeah, I think it's really important that they have access to participation in trials without parental consent, particularly for things that we know are safe, like PrEP and contraception. And, I just think when we're talking about high risk clinical trials, that's a whole different thing, but that's not what we're talking about most of the time.
Thanks, Audrey.
Mel, any questions?
I think I'm still, I don't think I expect a straightforward answer, but I am particularly interested in ensuring that we implement the results of implementation science and looking at ways to do that with a lot more attention to that in design. And perhaps you can give some examples of good practice with that. And then the second is really to congratulate the word of AHISA and to look at how we can improve access to that, because I think there is a lot within the realm of implementation science which is mystified and gets blurred with evidence-guided decision-making, with quality assurance, as Jane quite rightly pointed out, and quality improvement, and with different types of research. And I think very often research uses the word implementation science when it becomes a buzzword, but they are not really doing implementation science, but it becomes like a credibility. So I think the work of IHESA seems like it's doing a lot in the world of demystifying and making it more accessible. And I'd like you to speak to that.
Sure. Well, that's very exciting to hear. Sometimes when you're on the inside, it's hard to know the extent of things. I think part of it is sort of demystifying it, right? It seems big when you try to describe it, it seems complicated. And I think, I completely understand that there are times that people sort of just kind of tune out. And I think a large part of it is the sort of practical components. One of the trainings that we did that I mentioned actually was Audrey's team at WITS. And it was, somewhat didactic, but also very sort of group oriented, and let's sort of start to apply. And I think that it's the application piece that is when it starts to click. And I think that's and I think going back to this point of youth engagement and community engagement and that kind of thing, it is about making sure that they have those opportunities to be not just part of the discussion, but the part of the doing, so that they can see the clicking for themselves. That I think is really helpful. I think I would also say, one of the things I think we realized, and I sort of touched on this in terms of the sort of local alliances that we've been seeding, is realizing that countries are in really different places. I mean, researchers are in different places, the countries are different places, right? So also I think allowing things to be very context specific and sort of responding more to the individual needs and where things are. I think when we try to sort of cookie cutter and then copy paste is where we end up having all of these issues. And so, as much as we can sort of, do things that allow us to bring together the researchers who are working on things, but then also including all of those other members so that they can figure out for themselves and sort of design the way that they operate in a way, in such a way that, it works for them, right? The same way that, none of us are going to be doing things the exact same way in terms of even how we communicate with each other, but we have to figure out, what do you need? What do I need? How do we get together? But I think having that sort of, broad sort of communication, and again, ensuring that there's sort of this transdisciplinary, transsector kind of component, I think is what I think is one of the big things that's kind of come out of the sort of IHESA model, and that I think has real potential in other places.
As a member of IHESA, and I know folks from a number of organizations here are part of it, I totally agree. But I also, and I know like a big part of the new patch call was that you had to have members of Department of Health and community organizations on your team. And a lot of the partners in IHESA do have that. And those folks, like people from the Department of Health, have been active participants at a lot of the IHESA meetings and trainings. And so I think that was part of our D43 when we went to the Pettifor implementing partners, was like, we need to go to the people who are implementing the programs on the ground, because in my mind, the folks doing siloed HIV research that's not implementation science. We're not studying. I mean, you can think about it, I guess, but it's really about like understanding what's going on with the prevention programming and how can we improve it. So you really, I don't know, in my mind, you have to be working with the implementers and that's usually the Department of Health or organizations in partnership with Department of Health who are doing that work. So that feels essential. And I guess, Melanie, then the thought of like, how does that get fed back into policy? I think that would be a really cool thing for partner organizations in South Africa to think about with the DOH. I don't know what the SADOH has in terms of implementation science as a group, but thinking about that actual question you pose, I think would be really cool. I know Dr. Ramaswamy he does a lot of maternal and child health work as well. And in Ghana, I think they're just wrapping up a big program on maternal mortality and infant mortality that was actually like the Department of Health was the major partner in that program, and working closely to improve program implementation across the country. So I think those are some cool, interesting things when we can think about scale. And I think the department has to be a partner, otherwise it's not going to work, you know.
I think it's cool if anybody else is reading the chat. You know, I think people are sort of sharing how their groups are sort of doing things, and I think that's also part of it, is making sure that we share that, and that gets just as much of the sort of publication, you know, time as others. I think, you know, one of the things that we are constantly trying to figure out is, you know, what are the platforms by which we were able to share, you know, not just results but the process, and that kind of thing. You know, the same way that we also need to share our failures. I think that's a component too. So just to point to the chat and say, you know, John and Angelina, like, thanks for these are great examples.
And I wanted to call out, Susan, you might know more, but the Kenyan AHISA, I believe Dr. Kawango ago, it might have been pre-COVID. Anyway, they had an actual symposium or a conference that was specifically for adolescents in implementation science. And they actually were supporting adolescents and young adults to be the presenters and the training. And it was for them. It was not for, you know, established older researchers. It was a conference just for them. And so there are some really cool examples in the region of people doing kind of innovative things in the space.
Yeah, I'm going to put a link to their website in the chat as I'm speaking. But yes, they've done some really interesting. So there are sort of two, one of which was a group that Kawango had put together that was actually bringing together some youth who'd gotten Bill and Melinda Gates sort of seed funding to be conducting a very small sort of pilot kind of implementation science research. And so she had brought them all together so that they, at the beginning, doing more kind of a training on that. And then there is the KAHISA, which is the Kenya AHISA branch, that also has brought together youth and actually many others. And they've done it, I think, at least twice now. But yeah, that's been their approach. That's why I say it's interesting to have each of these be sort of locally led, because they very much sort of respond to the issues that they are sort of seeing. And so I think KAHISA especially kind of has spent quite a lot of time doing that sort of short-term capacity building with the sort of community members, and large, you know, quite a few of them I think have been youth.
Great. Thank you everyone for this great discussion, and thank you for the feedback on the chat, to Angelina and John for sharing about your cabs in Tanzania and in Nigeria, and to inviting the youth cab members. I was just texting with my DTHF colleagues and making sure that we invite our youth reference groups and cabs and experiential experts on to be panelists on calls like these. Definitely agree with that 100%. Just to summarize, I think, you know, a lot of what we talked about is really making implementation usable, accessible for all, and adapting some of the complex science and making it more simple in an African context. We need to have meaningful engagement of our expert consultants and the community with which we work, of adolescent girls and young women or men. And we also need strategies, not just understanding determinants, but really strategies for how best to implement evidence-based interventions. And there's more money. I think there's a lot more money, funding out there. So go get it. Go get the money and implement, but also work in alliance with the community, with your partners in the government and the community. And don't forget to link with SRH, sexual reproductive health, STIs. Yeah, and I think that's about it. So I want to thank you for attending today, for your interest, your questions, your sharing. Thank you to the speakers, panelists, the artists, DTHF, IAVI for sponsoring this event. As you exit the Zoom platform, there's going to be a brief evaluation. Please take a moment to complete it. Your feedback will help us to improve the webinar series, especially feedback about getting youth involved is key. And this session has been recorded and will be available on DTHF's YouTube channel. Thank you everyone for your time today. We really appreciate it. Take care.
Thanks everyone. Bye.
Thanks.